Good evening, everyone. Esteemed colleagues, special guests, we welcome you today to our grand rounds held by the Emergency Medicine Division here at the University of the West Indies, Mona campus. I am Dr. Gustav Gordon, a first-year emergency medicine resident, and I'll be the moderator for this evening's proceedings. Before we proceed, I would like to introduce our esteemed guests for today, Dr. Kevin Wade and Dr. Tamika Marchdona. Of course, I have to introduce our head of department, Dr. Eric Williams, our course program director, Dr. Simone French, and our supervising consultant for today, Dr. Romaine Edwards. Welcome to all other consultants in our emergency department, all our special guests and our colleagues joining us nationwide and regionally. It is with great honor that I welcome you today to our Grand Rounds presentation. The topic for today will be stroke management. Now, we know that stroke remains a leading cause of death and disability worldwide, and its timely and effective management is critical, especially for those working in the emergency department. So today we gather to appreciate the limitations faced, current practices, and promising interventions in an attempt to enhance our knowledge, refine our skills, and explore the latest advancements in stroke care. I encourage you all to actively ask questions and take this opportunity to strengthen your clinical approach. But before we begin, I want to implore you all, if you have not registered, to register. A link will be provided in the chat. And I ask that you all complete the pre-test. A link will also be provided in the chat. A post-test will be posted at the end of the discussion. So with that being said, I would like to officially begin our Grand Rounds presentation. But before we start, we want to start with a word of prayer. All right. Dear Lord, we thank you for the opportunity to be gathered here today, and we ask for wisdom and guidance as we discuss stroke management. May we learn, grow, and apply our knowledge with compassion and dedication. Bless our speakers and participants, and may our efforts lead to improved care for those in need. Amen. I want us to take a moment to reflect on our responsibility as healthcare providers, with hopes that our discussions today enhances our ability to make timely life-saving decisions. So I want us to commit ourselves to learning, teamwork, and the well-being of our patients. Now I'm going to introduce our first speaker or presenter, Dr. Zachary Gordon. He is a first-year emergency medicine resident. He has a special interest in critical care, and in his free time, he enjoys long walks on the beach. Please welcome him as he presents the cases for this evening's discussion.
Good afternoon, everyone. First, I'd like to thank Dr. Gordon. Good afternoon, everyone. First, I'd like to thank Dr. Gordon for that kind introduction. It's truly a privilege to be here today, sharing this platform with esteemed colleagues, mentors, and fellow practitioners. Today, we will be exploring stroke, one of the most pressing and time-sensitive emergencies in medicine. Our discussion will take us through the past, present, and future of stroke management, highlighting how far we've come, the challenges we still face, and the challenges and innovations shaping the next frontier of care. To illustrate these concepts, I'll be presenting 3 cases, each emphasizing different challenges and critical aspects of stroke management in the emergency setting. These cases will not only highlight the complexity of diagnosis and treatment decisions, but also underscore the real-world barriers we encounter in optimizing patient outcomes. Stroke care is constantly evolving, and as we dissect these cases, I hope we can learn from each other, reflect on our practices, and glean insights that will refine how we manage stroke in our respective roles. With that, let's begin. Our first case begins with a patient, i.e., an 88-year-old male who presented at a peripheral hospital 3 hours after the onset of his symptoms. The presenting complaint was slurred speech, left-sided weakness, and that started 3 hours ago. So we had an elderly male who presented noting that upon going about his usual routine, he began experiencing left-sided weakness and associated slurred speech. His past medical history included a history of hypertension for over 30 years. He's known to be dyslipidemic for over 10 years. He noted that he was poorly compliant with medication, and he had a 20-pack-year history of smoking cigarettes. His vitals included a temperature of 36.7, a pulse of 106 beats per minute, a blood pressure of 182 millimeters of mercury, a respiratory rate of 20 breaths per minute, and a GMR of 5.7 millimoles per liter. Significant findings were limited to his central nervous system. He was oriented to time, place, and person. He was noted to have a left hemiparesis with a power of 2 out of 5 to the upper and lower limbs, mild dysarthria. His sensory exam was unfortunately not documented. On examination, he was noted to be anicteric, acyanotic, afebrile to touch. Mucous membranes were pink but dry. His cardiovascular system, his respiratory system, and his abdominal system were all unremarkable. So the assessment at the time was an acute stroke and mild dehydration. The plan was to get an IV access, to take off relevant bloods, including a complete blood count, a urea and electrolytes, a random blood glucose, to get an electrocardiogram, to have blood pressure monitoring, to commence IV fluids at 100 cc's per hour normal saline, to get a CT brain as soon as same is available, to give him a stat dose of atorvastatin 40 milligrams, PO, and to refer him to internal medicine. In terms of his ECG, it showed a sinus rhythm with left axis deviation. And in terms of his labs, it showed a mild hypochromic microcytic anemia with a noted pre-renal azotemia. At the time of presentation, CT was not done due to the fact that there is no CT machine on site. Preparations were made for the CT to be facilitated off-site, but due to challenges in transport and staffing, this led to significant delays. The patient was admitted to internal medicine where his pre-renal azotemia was treated with IV fluids, but despite early presentation, the CT brain was not done until day 5 of admission. Here we can see a CT brain, which shows an acute right MCA territory infarct with an aspect score of 5 on the background of small vessel ischemic disease. And if you look, you can also see a chronic left occipital infarct. So looking at it in more detail, there's a wedge-shaped hypodensity that spans the gray-white interface within the right frontal, parietal, and temporal lobes with associated loss of sulcation and effacement of the right ventricle. So some major discussion points, we can see that the plan included CT brain as soon as available, implying image delays at the facility. Peripheral hospitals may lack neurologists, stroke units, or rapid intervention teams, delaying essential treatment of patients. If the patient needs urgent referral to a tertiary or an imaging center, logistical challenges could further impact diagnosis and prognosis. A complete stroke protocol includes an immediate CT brain to rule out hemorrhage, a CT angiography to assess large vessel occlusion if thrombectomy is an option, a carotid Doppler to see if there's any carotid stenosis, and an echocardiogram. So here ends the first case. Case 2. This followed a patient, PL, a 62-year-old male. The historian was his wife, and he resided in Jamaica. The presenting complaint was decreased responsiveness for 2 hours. The patient presented initially complaining of numbness to his right upper limb, which then progressed to weakness. He also lost the ability to stand upright. Patient was then noted to have become mute, but seemed to have maintained awareness. He then signaled to his wife for water, where it was noted that he could not swallow. Subsequently, he developed jerky movements to the right upper limb, then generalized to the entire body. He was noted to have loss of consciousness at this time, as well as loss of fecal and urinary continence. This episode lasted 5 minutes. The patient was stuporous after this event and had an episode of vomiting. Of note, the patient had been complaining of severe headaches the night prior to presentation. The patient was then brought to the UWI for further care. Important negatives include no history of trauma, there was no stigmata of infection, there were no ill contacts, and at baseline, the patient is ambulant, conversant, and self-caring. His past history included a history of hypertension for 10 years, a prior stroke that had no residual deficits. The timing and nature of same was unknown. He had a past surgical history of a spontaneous pneumothorax requiring surgical intervention, a drug history that they were unsure of at the time. He had a 40-pack year smoking history, and he admitted to social alcohol use. His initial vitals included a blood pressure of 219 over 107 millimeters of mercury, a respiratory rate of 24 breaths per minute, an SpO2 of 96%, and a GMR of 10.9 millimoles per liter, and a pulse rate of 76 beats per minute. On examination, there was a middle-aged male who was in no cardiopulmonary nor painful distress. There was adequate hydration status was noted, but they did note some vomitus to the shirt. His significant findings were limited to his central nervous system, where he was noted to be drowsy and minimally responsive. His GCS was noted to be 10, with a breakdown of E3, B1, M6, with right-sided nasolabial flattening. He was noted to have a right hemiparesis with weakness. The power was scored at 2 out of 5 to the entire right upper limb and 1 out of 5 to the entire right lower limb. His left side had normal power at 5. His pupils were noted to be 3 millimeters in diameter and sluggishly reactive bilaterally. There was no nystagmus nor gaze preference noted. His respiratory system, his cardiovascular system, and his abdomen were all noted to be unremarkable. The assessment at the time was an acute cerebrovascular accident with an NIHSS of 23. There was also an assessment of new onset partial seizures with generalization, a hypertensive emergency, and possible aspiration. The emergency department plan at the time included an IV access to take off a complete blood count, a urea and electrolytes, a calcium, a phosphate, magnesium, albumin, and a PT-PTT, to get an electrocardiogram, to get a CT brain, to obtain a chest X-ray, to cite a pulse tubing, to have strict input-output charting and a urinalysis. He was to get 2 grams of roquefin IV stat, dilantin 1 gram over 30 minutes. He was to compense IV fluid at 120 cc per hour normal saline, and to be referred to the internal medicine team. Immediately after initial assessment, the patient was carried to the radiology department for a door to presentation time of 67 minutes. While on the table of the CT machine, he became agitated and had an episode of vomiting. As a result, the radiology resident notified the ED physician of the acute deterioration, and the patient was transported back to the emergency room for stabilization. The radiologist on call was able to determine the presence of a large bleed, but unable to give details regarding same due to severe motion artifacts. Upon return to the ED, patient was immediately reassessed. He was noted to be in significant respiratory distress. He was hypoxic at 56% and distressed at a rate of 32 breaths per minute. He was noted to have vomitus in the mouth, which was suctioned. His GCS had remained stable. The patient was given an NG tube. He was given Gravol 50 milligrams IM stat, as well as a stat dose of Flagyl 500 milligrams IV. His repeat saturation was now 96% on 10 liters oxygen, and his respiratory rate was 28 breaths per minute. He was promptly seen by the internal medicine resident on call. The history and physical exam was now compounded by the patient's aspiration, patient was found to be in respiratory distress with harsh breath sounds. Due to barriers inclusive of the time taken to adequately resuscitate the patient and stabilize the patient, availability of the CT scanner due to other emergencies, and staffing constraints, his final door to CT time was 663 minutes or 11 hours. The internal medicine assessment was an acute hemorrhagic stroke with an NIHSS of 23 on presentation. This was complicated by seizures and now an aspiration pneumonitis, as well as chronic hypertension. The plan was to initiate roquefin 1 gram IV OD to give him bisolve 10 mils through his NG tube, normal saline nebs, as well as to commence sliding scale insulin and to give him pantoprazole 40 milligrams IV. He was for neuromonitoring and vital skew hourly. He was for strict GMR profiling. He was to be kept NPO, aspiration precautions. They were to ensure the CT and chest X-ray, metabolic panel, an echocardiogram and carotid Doppler, and to have a neurology consult. His labs were remarkable for mild renal impairment. His ECG showed a sinus rhythm with a first-degree heart block and non-specific T-wave abnormalities. His final CT brain showed hyperdense material in the cerebellum, suggestive of an acute intraparenchymal hemorrhage with obstructive hydrocephalus. Here we can see there's an amorphous high-density material consistent with acute blood seen centered in the cerebellar vermis. There's no midline shift nor tonsillar herniation. There's a complete effacement of the aqueduct of Sylvius and the fourth ventricle. The temporal horns of the lateral ventricles and third ventricle appear prominent, suggesting a developing non-communicating hydrocephalus. I'm just going to replay the video one more time just to ensure that everybody gets to see it. Excellent. So his admission on clinical course, he was assessed as a hypertensive emergency, receiving GTN infusion at 5 mics per minute. His BPs range from 253 to 110 and 262 to over 146. An acute intracranial hemorrhage with a now GCS of 3 out of 15, and that aspiration pneumonitis witnessed, and he was on IV antibiotics, roquefin, as well as Flagyl. The continued plan included an ICU consult as this patient required intensive care and close monitoring. He was referred to neurosurgery to determine if there was any possible surgical role. The patient's hypertensive emergency was to be treated with a GTN infusion. He was admitted under general medicine. A family meeting was scheduled to discuss the patient's prognosis. Neurosurgery had stated that they were unable to determine if the low GCS was due to the brain bleed or the resulting hydrocephalus. Consideration was given to an extraventricular drain, but noted surgical intervention was likely to be of limited benefit due to the location and the extent of the bleed. Medical management was recommended to be most appropriate. ICU came and gave their recommendations. They noted he was a poor ICU candidate and there was no space available. They recommended neuro observation, to have aspiration precautions, to have a target SpO2 of over 94%, to have chest and limb physiotherapy on board, and to have a family meeting regarding the guarded prognosis. A family meeting was held between the internal medicine team and the wife. The wife was informed of the diagnosis and the severity of the current illness with the use of diagrams. They related his current state to the current diagnosis, and understanding was achieved. Informed of the current limitations regarding the ICU bed availability to advance care, and the likelihood of death was relayed. Approximately 24 hours post-presentation, the patient had a witnessed respiratory and cardiac arrest. Despite 20 minutes of ongoing CPR as per ACLS guidelines, the patient remained in asystole with no respiratory effort and fixed and dilated pupils. The patient was pronounced dead. So some major discussion points: stroke presentation and recognition. This sudden neurological deficits, including hemiparesis, speech difficulty, altered consciousness, should prompt urgent stroke evaluation. An NIHSS score of 23 indicates severe stroke with high morbidity risk. The importance of early imaging in stroke management should be done urgently to differentiate ischemic versus hemorrhagic strokes. If movement or cooperation is an issue, preparing for airway protection before sedation may improve outcomes. Repeat imaging should be prioritized if initial scans were compromised. Focal seizures progressing to generalized seizures in strokes may indicate cortical involvement or hemorrhage. High aspiration risk in stroke patients require early NG tube placement, strict aspiration precautions, and head elevation, and to assess for intubation if warranted. So now we begin with case 3. Case 3 followed a 65-year-old male. The historian was himself and the son, and the resident was Jamaica. The presenting complaint was unable to speak nor move the left side of the body 2 hours ago. The patient was seen immediately on arrival to the ED with a door-to-physician time of 2 minutes. Patient reported having sudden onset mutism and an inability to grasp objects with his left hand, and also complained of weakness to his entire left upper limb and lower limbs. He was initially carried to a private institution, but due to the unavailability of CT, the patient was carried to the UWI for further treatment. His past medical history included a history of hypertension, diabetes mellitus. He was status post total left knee replacement 2 weeks prior. He had a history of embolism to the right foot and with a below knee amputation 1 year ago. And he had a cerebral vascular accident 20 years ago. The vitals on presentation: his blood pressure was 157/95. His respiratory rate was 22 breaths per minute. His pulse rate was 96 beats per minute. His SpO2 was 90%, and his temperature was 36.1 degrees Celsius with a GMR of 9 millimoles per liter. In terms of his general examination, there was an elderly male in no obvious painful or respiratory distress. His mucous membranes were pink and moist, and there was an adequate salivary pool noted. In terms of his central nervous system, he was conscious but noted to be drowsy, requiring constant verbal and physical stimulation. The GCS was assessed as 9 with a breakdown of E2, V2, M5. His pupils were equal and reactive to light. There was no orientation to time, place, nor person. And there was an inability to assess higher mental function due to his verbal deficits. Significant findings were noted to cranial nerves 3, 4, and 6, which showed a horizontal gaze preference to the right. Cranial nerve 7 had findings in keeping with a left upper motor neuronal lesion. The rest of the cranial nerves were noted to be unremarkable. His power was 5/5 to the right upper limb throughout, and his power was 5/5 to the right lower limb throughout. His power was 0/5 to the left upper limb throughout, and the 0/5 to the left lower limb throughout. They were unable to assess sensory and coordination. His cardiovascular system, his abdominal system, and his respiratory system were all unremarkable. The emergency medicine assessment was an acute stroke with an NIHSS of 20, hypertension, and diabetes mellitus. The plan at the time was to gain an IV access, take off a complete blood count, a urea electrolytes, a PT-PTT, to have IV fluids. He was to get a CT brain and a CT angiography with an aimed door to CT time of 20 minutes. The stroke protocol was activated. He was referred to internal medicine and neurosurgery to review case to determine thrombolysis and thrombectomy once the CT was done. The ECG showed a sinus rhythm with a left axis deviation. His labs showed a mild hyperchromic microcytic anemia and a mild hypernatremia. In terms of his target times, the door to imaging time was 35 minutes, and the door to interpretation time was 60 minutes. His CT showed features suspicious of an early right MCA territory infarct. The aspect score was 7. A chronic MCA territory infarct to the left, and there was no evidence of an intracranial bleed. So looking at his CT, There's a subtle hypodense area spanning the gray-white matter of the right frontoparietal lobes. This is associated with sulcal effacement with mild scalloping of the left lateral ventricle. There's a wedge-shaped hypodense area in the left parietal lobe, which is similar in attenuation to the CSF. There's also a chronic left basal ganglia infarct. These conglomerate of features are suspicious for an early right MCA territory infarct with an aspect score of 7. I'll just replay the video one more time so everybody can see. The plan post-CT was a joint decision between internal medicine, neurosurgery, and emergency medicine. The thrombolytic checklist showed no absolute contraindications. The right knee surgery 3 weeks prior was a relative contraindication. The risk of the procedure was explained to the next of kin and informed consent was achieved. A joint decision was made to proceed with systemic thrombolysis. Tenecteplase was collected from the emergency pharmacy. It was dosed to a weight of 90 kilograms. It was calculated to be 10,000 units. The patient was placed on a cardiac monitor and pulse oximetry. Tenecteplase 10,000 units was given via slow IV push for a final door to needle time of 80 minutes. Post-thrombolysis, the patient was noted to become more alert and responsive. He began following one-step commands. The right gaze preference and left nasal labial flattening began to improve but did not subside, and the power to the left upper limb improved to 2 out of 5. His NIHSS score was now 18. The plan was for vitals Q 15 minutes for 1 hour, then hourly for 4 hours, neuro observation, and to monitor for bleeding. Post-thrombolysis, 4 hours, his vitals had remained stable. He was moderately drowsy. He was able to now follow 2-step commands. His dysarthria persisted. The left upper motor neuron lesion persisted, and the power remained at 2 out of 5 to the left side throughout. His NIHSS was now 16, coming from 20. It was to continuous serial neurological examinations, repeat CT brain 24 hours post-thrombolysis, and to ensure IV fluids. 12 hours post-thrombolysis, upon review with the consultant on post-duty ward rounds, the patient was now alert, oriented to time, place, and person. He was speaking in phrases. He was able to identify objects. The power had increased to 3 out of 5 in the left upper limb and lower limbs. His NIHSS score was now 10. Patient was now for admission to the ward under general medicine. 24 hours post-thrombolysis, his vitals had remained stable. His neurology, he was oriented ×3. His speech was fluent. He followed 3-step commands. His higher mental function had now returned to baseline. Power remained at 3 out of 5 to the left side. He had improving cranial nerve 7 deficits. His NIHSS score was now 9. He had a repeat CT brain 24 hours post, which showed stable interval findings. The plan was to ensure physiotherapy, DVT prophylaxis, to have an echocardiogram and a carotid artery Doppler done, and to aim for target BPs of 100 to 150 systolics. On day 5 of admission, the patient had a steady improvement in neurology throughout his entire admission. Higher mental function returned to baseline. Left-sided facial weakness persisted though. Power was not left to the left upper limb was now 4 out of 5 throughout. His NIHSS was now 8. His echocardiogram and carotid artery Doppler were both unremarkable. And the patient was discharged on aspirin 325 milligrams, rosuvastatin 20 milligrams, and he was to follow up in general medicine clinic and to continue physiotherapy. So some major discussion points we can talk about are: where should patients who underwent systemic thrombolysis be managed? Alteplase is the gold standard in acute stroke, but tenecteplase is an off-label but an acceptable alternative to thrombolysis. So here ends the cases. I hope you guys actively listened and we have some questions to come now.
Thank you, Dr. Zachary Gordon, for going through the cases with us. I see some questions in the chat. Cameron, was the second case intubated? No, the patient in that case was not intubated. The second question, can use of GTN infusion in intracranial bleed worsen the ICP? So in short answer is yes. We know that GTN is a potent vasodilator, so it may lead to cerebral vasodilation, which may increase cerebral blood flow, leading to an increase in intracranial pressure. So yes, it can increase or worsen ICP. Third question was GTN infusion. Why was GTN infusion used versus allobetalol infusion? Allobetalol is preferred to GTN, but it was ordered by the internal medicine team. I believe it had to do with availability of labetalol here at the institution. Yes, labetalol is preferred to a GTN infusion, controls the blood pressure better. Fourth question, was GTN contraindicated given the raised ICP? So yes, GTN use. Yes, so we know that GTN-induced vasodilation can cause an increase in cerebral blood flow. So it's cautioned. So they said that you should caution the use of GTN, especially in patients with increased intracranial pressure. So yes, there was a relative contraindication there. Any more questions in the chat? No, not seeing any more. So at this time, I would like to introduce our second speaker, Dr. Carlton Miller. He's a third-year emergency medicine resident. He's known for his interest in 12-lead electrocardiogram theory and analysis. Can stop him anywhere and show him an ECG. In his free time, he enjoys playing casual football. Please welcome him as he leads this evening's discussion on how the emergency medicine management of stroke has evolved.
Okay. Good evening, everybody. Welcome again to our grand rounds. Thank you for this opportunity to impart knowledge, and I hope you find the information. Okay, so we'll begin this discourse with speaking about the history and evolution of stroke assessment and management, briefly. Hold on. All right, sorry about that. Okay, so here we have the Yalta Conference, also known as the Big III conference. So this was held in 1945, and shown here are Winston Churchill on the left, President Roosevelt in the middle, and Joseph Stalin on the right. Undoubtedly, this was a major event in human history. These powerful men, like many others before and after, right, proved powerless to combat the medical disaster that is a stroke. President Roosevelt died 2 months following this historical meeting of a hemorrhagic stroke in 1945. Stalin died 8 years later in 1953 of a hemorrhagic stroke, and Churchill died in 1965 due to complications of a stroke. Okay. James Copeland's 1850 instructive text, Causes, Nature, and Treatment of Palsy and Apoplexy, stated, apoplexy is best treated with bloodletting and purgatives. However, these treatments prove to be seldom effective. Arguably, if these world leaders had their strokes prevented or treated successfully, the world today may have been a very different place. This is the impact of cerebrovascular disease on humanity. The history of human progress in understanding and treating stroke is fragmented with gradual strides over many centuries. To arrive at present-day understanding and treatment required advancements in multiple scientific fields which occurred sporadically. Galen, the renowned Greek surgeon, physician, and philosopher who lived AD 131 to 201, was aware that hemiplegia resulted from a lesion in the opposite side of the brain, but the cause was poorly understood. The father of medicine, Hippocrates, described the syndrome in detail and named it apoplexy in the 5th century. In Greek, apoplexy means struck down by violence, illustrating the sudden and often catastrophic presentation of this condition. Following this, for many centuries, the pathophysiology of stroke was very poorly understood. In 1658, Johann Wepfer, Swiss pathologist and pharmacologist, discovered that apoplexy was caused by a disrupted blood supply from bleeds and clots based on his post-mortem analysis. Felix Marchand was a German pathologist, and in 1904, he introduced the term atherosclerosis and suggested it to be responsible for the obstructive processes in arteries. Atherosclerosis is derived from the Greek word athero, which means paste, and sclerosis, which means hardening. Therefore, it is the hardening of an artery due to an atheromatous plaque. The Merriam-Webster Collegiate Dictionary documents the interchangeable use of cerebrovascular accident with stroke as early as the mid-1930s. No source is credited with the change in nomenclature from apoplexy to stroke or cerebrovascular accident. However, the term stroke became popular in the 1900s, emphasizing the urgency of the clinical condition. By the 1950s, stroke became the name of the major scientific journal on the subject, further cementing the use of this terminology. Charles Miller-Fisher, right? You may be familiar with the Miller-Fisher syndrome or variant of Guillain-Barré. It's named after this gentleman. Fisher and colleague Adams in 1964 published the series Cerebrovascular Diseases, Neuropathological Progress. Their publications identified 1, atherosclerosis and associated atherothrombosis, atheroembolism, and also small vessel lipohyalinosis as the underlying pathology in stroke. Concepts that we continue to evolve today. The landmark 1948 Framingham study was the first to demonstrate the link between hypertension and stroke. This trial identified many of the other risk factors of cardiovascular disease in general, paving the way for possible preventative treatments. Now, the evolution of stroke in medical practice, all right, progressing from this point onward, can be divided into advancements in diagnosis through neuroimaging and advancements in treatment, and which were both medical and surgical. We're going to take an accelerated approach to come to the present, right? Notably, advancements in preventative therapy are important, but won't be covered in this presentation. Now, this is Wilhelm Röntgen. He discovered X-rays in 1895, and this propelled mankind into a new era of medical diagnostic technology. The first X-ray he took was an X-ray of his wife's hand. However, plain X-rays are highly limited in visualizing intracranial structures unless they are heavily calcified. Fast forward, computed tomography revolutionized stroke diagnosis and care and allowed us to diagnose confidently and also differentiate ischemic from hemorrhagic stroke. Godfrey Housenfield is credited with developing the first commercially viable cranial CT scanner in the early 1970s. This is Raymond Damadian. He developed the first MRI machine in 1977. These became commercially available in the 1980s and their use quickly became widespread. These are the investigators of the landmark National Institute of Neurological Disorders and Stroke 1995 trial. In quotation, until today, stroke was an untreatable disease. Words by James Grotta, presenting the findings of the NINS study, December 14, 1995. Tissue plasminogen activator was the first effective medical treatment for acute ischemic stroke, and to this day remains the only effective medical treatment. It gained FDA approval in 1995, and the landmark NINS trial established the efficacy of TPA, or tissue plasminogen activator, within a 3-hour window and stimulated further research and clinical trials. Okay, advancements in surgical treatment. So surgical for acute ischemic stroke is catheter-directed. Catheter-directed vascular techniques were first developed for cardiac and peripheral vascular disease. However, this discourse will focus on the establishment of catheter-directed stroke treatment and thrombectomy. The PROLISE in acute cerebral thromboembolism trial, PROACT 1 and 2. These were in 1996 and 1998, right? These trials tested catheter-directed thrombolysis with pro-urokinase in patients with middle cerebral artery occlusion treated within 6 hours of stroke onset. This gave hope to extend the therapeutic window of ischemic stroke. All right. PROACT 1 was a small study which showed promise, prompting the larger PROACT 2. Ultimately, PROACT 2 results were marginally beneficial, and so catheter-directed intra-arterial thrombolysis with pro-urokinase did not receive FDA approval. The recanalization rate was only 18%, but this 18% formed a benchmark against which future devices will be tested. Subsequently, many devices failed to be of clinical benefit, but the mechanical embolus removal and cerebral ischemia retriever, a mouthful, was the first efficient thrombectomy device. Now, the advantages of mechanical thrombectomy were: 1, improved recanalization rates, reduced hemorrhage risk by eliminating thrombolytic usage, and improved outcomes overall. So the Mercy retriever gained FDA approval in 2004, and it had a 48% recanalization rate. Stent retrievers are the most commonly used devices today. They were initially coronary self-expanding stents used off-label as a bailout procedure when standard devices failed. Subsequently, modern stent retrievers proved to have 90% recanalization rates in trials in 2014 and 2015. Okay, so now we will discuss current stroke management. Okay, I'm a fan of memory aids, so I'll be sharing with you a few aids that I hope you will find beneficial. Let's begin. Okay. Hold on. Okay, good. So this discourse will focus on current acute emergent management of stroke. Management of acute stroke may be divided into general management and management specific to the type of stroke. The initial approach. In the ideal setting, the pre-hospital team does the initial assessment and stabilization, then rapidly alerts a receiving hospital, which commences the stroke alert before patient arrival. Pre-hospital assessment allows patients to be rapidly transported to a hospital with the right facilities to manage the patient. Now, to do this, which is to find or to determine the right hospital to the hospital with the right capabilities to treat the patient, right? These providers must assess whether or not the patient would benefit from reperfusion therapy. And secondly, they must assess the likelihood of large vessel occlusion which is essentially a stroke likely to be, again, amenable to thrombectomy. So this assessment for large vessel occlusion is done with clinical tools. So some of these tools include the pre-hospital VAN tool, the National Institute of Health Stroke Scale, the Cincinnati Pre-Hospital Stroke Scale, and there are others. So in this discourse, I'll just briefly mention or expound on the pre-hospital VAN tool, and VAN is a mnemonic for vision, aphasia, and neglect. In its pilot study, the VAN tool was found to be 100% sensitive and 90% specific for large vessel occlusion. Okay, a bit about how it's done. So first, you have to assess for weakness by asking the patient to put their hands out, right? If they have weakness, then you can proceed to the next step. And you're going to assess for visual disturbances such as field cuts or diplopia, aphasia, which could be expressive or receptive, and you're also going to assess for neglect. So the presence of weakness with at least one of those three means that the patient is VAN positive. Okay, so in the ED, the initial approach begins with rapid primary and secondary assessment with management of the patient's airway, breathing, and circulation. Once a stroke is confirmed, a stroke alert should be initiated. The single call stroke activation system. This is the global standard, right, which alerts all multidisciplinary team members involved in the management of these patients with one call or alert, as opposed to having to call each of these persons individually. A multidisciplinary stroke team may include, but is not limited to, emergency physicians, internists, neurologists, intensivists, senior nurses, radiologists, radiographers, and pharmacists. More about the initial approach. So once the airway, breathing, and circulation are stabilized, a rapid history is obtained, a rapid physical examination is done inclusive of calculation of the NIH stroke scale, and initial investigations are requested. So the National Institute of Health Stroke Scale. It's the preferred severity scale. It's rapid, accurate, reliable, and can be performed by a broad spectrum of providers. It has been validated in a large amount of landmark studies. Okay, so what is the utility of the NIH stroke scale? It can be used to categorize whether or not the stroke will benefit from thrombolysis or thrombectomy based on severity, and it can predict the likelihood of large vessel occlusion. So I've been using this term large vessel occlusion. So what do I mean by this? In this context, I mean proximal intracranial vessels, especially the internal carotid and middle cerebral artery, right? These vessels typically result in massive debilitating stroke, or rather occlusion of these vessels typically results in massive debilitating stroke with greater risk and less therapeutic response to thrombolysis. Thrombectomy is often the best therapeutic option in these cases. So the National Institute of Health Stroke Scale. This table illustrates the classification of severity. So 0 is no stroke symptoms, 1 to 4 is minor, 5 to 15 is moderate stroke, 16 to 20 is moderate to severe, and 21 to 42 is severe stroke. So this scale is actually quite a large scale, and practice may dictate that you do the physical examination with the assistance of a chart. However, conceptually, right, the scale can be remembered as A, E, I, O, U, and I'm going to get into it. So A is for alertness, E is for eyes, input, I is for input, which is the sensory components, O is for output, which is the motor components, and U is for you need to talk to the patient to assess the language components. Okay. And also, an NIHSS stroke scale of greater than or equal to 6 has traditionally been used to predict a cortical stroke. So here are the components. 3 components for alertness, 2 components for assessment of the eyes, 2 components for for sensation, 4 components for motor, and 2 language components. All right, back to the initial approach. So the two most important investigations are, one, a bedside glucose, and two, a non-contrast computed tomography of the brain. If indicated, thrombolysis should not be delayed to wait for platelet or clotting studies unless there's a clinical reason to suspect that they may be abnormal. The following investigations are done routinely in most patients. These include a complete blood count, serum electrolytes, and urinary abundant creatinine, sorry about that, coagulation studies, a 12-lead electrocardiogram, and in select patients, other tests may be indicated on a case-by-case basis. So these include liver function tests, toxicology screening, blood alcohol levels, pregnancy testing in women of childbearing age. You may consider an arterial blood gas, chest X-ray. A lumbar puncture may be considered if subarachnoid hemorrhage is suspected with a negative CT, an electroencephalogram if seizures are suspected, and cardiac biomarkers. Okay, so this slide is to illustrate important time stipulated by the American Stroke Association that will optimize patient outcomes, right? So to enhance or to improve the proportion of patients that receive thrombolysis, we should aim for door-to-physician times of less than or equal to 10 minutes, right? Door-to-stroke alert of less than or equal to 15 minutes, door-to-CT time of less than or equal to 25 minutes, door-to-interpretation time of less than or equal to 45 minutes, and door-to-needle time of less than 60 minutes. Okay, so the decision for plain CT versus CT angiography. Best practice dictates that the patient gets CT angiography at the same time as the plain CT if large vessel occlusion is suspected and mechanical thrombectomy is indicated and available. More on this coming up. So we're talking about imaging. Let's touch on the aspect score. So the aspect score, which stands for the Alberta Stroke Program Early CT score, is a 10-point quantitative topographic CT scan score used in patients with middle cerebral artery stroke. Topographic meaning that we're literally looking at anatomical regions on the CT scan and deciding whether there are ischemic changes visible on the scan. All right. So a very good scan is a 10, and the worst possible scan would be a 0. All right. An aspect score less than or equal to 7 predicts a worse functional outcome at 3 months as well as symptomatic hemorrhage. Okay, moving on. So this slide is a simplification, and we're going to go into more detail going forward. But I would like to introduce some concepts, right, to lay the foundation for what we're going to speak about. Okay, so this slide bridges the discussion between image acquisition and reperfusion choice. The take-home messages that I would like to communicate from this slide include: 1, for the less than 4.5-hour window, both TPA and thrombectomy are options. The priority is rapid image acquisition, as there will definitely be salvageable penumbra. And we're going to go into what I mean by penumbra. Okay, for the 4.5 to 6-hour window, okay, thrombectomy is proven to be highly safe and efficacious at less than 6 hours. CT angiography may be sufficient for the thrombectomy decision. CT perfusion may give more information. And we're going to speak about CT perfusion imaging soon as well. After 6 hours, many patients may still experience a therapeutic benefit from thrombectomy, but they need to be carefully selected. And we need to know they have small core infarct and a large penumbra. Okay. So, acute stroke management. Treatment is guided by time from onset of stroke, severity of neurological deficit, and findings on neuroimaging, such as ischemia, such as it being an ischemic stroke or a hemorrhagic stroke. So I promised to explain a few terms, so I'm going to go ahead and do that. So what do I mean by penumbra? So in an ischemic stroke, right? You're going to get two types of injury. You're going to get cell death and cell necrosis, which is the infarct, and then you're going to get reversible cell injury, which is the penumbra. So these areas of brain tissue are impaired in function, but salvageable, right? So a lot of the advances in acute stroke treatment has been geared towards establishing how much penumbra we have left, which we can salvage. Okay, so what is CT perfusion imaging? Well, CT perfusion imaging uses contrast and serial imaging to identify the size of the ischemic core and the size of the ischemic penumbra, using concepts such as Tmax and cerebral blood flow, which I won't get into too much detail. Another important imaging technique is also diffusion-weighted imaging, fluid attenuation inversion recovery, MRI. Okay, so what this really looks for, right, is cytotoxic edema and vasogenic edema. So interestingly enough, what has been found is that cytotoxic edema, which can be picked up, or I'll use the term picked up, can be picked up on MRI. It can be picked up on MRI as early as a few minutes after stroke onset. Fine. So cytotoxic edema is picked up on diffusion-weighted imaging. Now, or perhaps I should pull back a little bit. So both of them are MRI sequences. So you do the diffusion-weighted imaging and then you do the flare, right? And the diffusion-weighted imaging picks up the cytotoxic edema, which comes up within minutes, right? Fine. And then vasogenic edema can be picked up on the flare approximately 4.5 hours after the onset of the stroke. So hence, for example, if you're DWI positive and flare negative, it means that it's a fairly early stroke and is quite likely to respond well to reperfusion strategies. Okay, moving on. So the broad overview of the management of ischemic stroke is therapeutic interventions, which can be medical or surgical, and supportive care, which can be medical or surgical also. So medical therapeutic management. Thrombolysis, right? Alteplase is the preferred agent according to the American Stroke Association 2019 guidelines and the European Stroke Association 2021 guidelines. Now, tenecteplase, though effective and approved for thrombolysis of acute myocardial infarction, is currently used off-label as a thrombolytic in stroke. Both organizations advocate for liberal use of thrombolytics. Okay, now we're going to speak a little bit about how to determine who is eligible for reperfusion or for thrombolysis, right? And this can be divided according to the duration of onset of the stroke, accordingly as the 4.5-hour window, the 4.5 to 9-hour window, and special circumstances, including stroke on awakening. All right, so I have another memory aid for you. So the memory aid BAD can be used to remember the indications for each window. So BAD stands for B, low bleed risk, A, acceptable imaging, D, disabling stroke. So within the 4.5-hour window, you need low bleeding risk, which is absence of contraindications to thrombolysis, an acceptable aspect score, meaning greater than or equal to 6, and the patient should have clinically disabling stroke, at least an NIHS stroke scale greater than or equal to 6. And we're going to use the same mnemonic for all the windows. So let's look at the 4.5 to 9-hour window. Again, we want a low bleeding risk, so absence of contraindications, an acceptable penumbra according to CT or MRI perfusion imaging. We kind of spoke about that a little bit just now, and we'll speak more coming up. And again, disabling stroke as evidenced by the NIH stroke scale. All right, and finally, stroke on awakening from sleep or known onset greater than 4.5 hours, You want a low bleeding risk, an acceptable MRI, diffusion-weighted imaging at flare mismatch, which is what we spoke about earlier, and absence of contraindications. Okay, so we're going to speak about some important trials that have shaped our current management. So this slide is supposed to illustrate two windows. You have the NINS window, which was the initial window, which is clearly comparatively smaller than the ECAS-3 window. So ECAS-3 was a trial in 2008, and it was another landmark trial. So the NINS trial established the 3-hour window for thrombolysis. ECAS-3 in 2008 established the benefit of thrombolysis in the 4.5-hour window and informed further research and laid the foundation for current protocols. Okay, the Wake Up trial in 2018. This was important and groundbreaking because 25% of strokes occur in sleep. This trial used MRI, DWI flare to identify which strokes would benefit from thrombolysis. That is to say, which strokes would clinically behave like strokes less than 4.5 hours of onset based on image characteristics on fluid attenuated inversion recovery. The 2019 EXTEND trial. This trial investigated if penumbra core mismatch between 4.5 to 9 hours was amenable to thrombolysis. So in the EXTEND trial, a penumbra to core mismatch ratio greater than 1.2 was used as the predicate, as the inclusion criteria. There were other inclusion criteria and exclusion criteria, but I'm just giving you the broad overview. Okay, so contraindications to thrombolysis. These contraindications can be categorized as absolute or relative. The most feared complication of thrombolysis is intracranial hemorrhage. The rate of intracranial hemorrhage after thrombolysis with alteplase in an ischemic stroke is approximately 2%. Tenecteplase has comparable rates of complications. Though physicians must be cognizant of all the contraindications to thrombolysis, best practice is to utilize the aid of a thrombolysis checklist. So the following slides are to illustrate examples of a pre-hospital checklist and a comprehensive in-hospital checklist. Okay, so this is a pre-hospital thrombolysis checklist. And this is an in-hospital checklist, which is very extensive. Okay, moving on. So now we're going to talk about, in more detail, the drugs that we're going to be using. So, alteplase, also known as Activase or Actylase. This is tissue plasminogen activator. It has moderate fibrin specificity, which means it binds to fibrin-bound plasminogen in clots, forms plasmin, which dissolves the thrombus, and it does so in preference to widespread systemic activation of plasmin. Therefore, there's expected to be less bleeding as compared to thrombolytics, which are non-fibrin specific. Okay, so a few take-home points. One, alteplase was established by the NINS trial, which I mentioned earlier, and has been used in multiple landmark studies thereafter. But alteplase has been around for a very long time. It was approved in 1987 for use in myocardial infarction. Now, it is rapidly metabolized and has a half-life of 5 minutes, and it's given as a bolus, then maintenance, right? So why is this? Well, it has to do with the half-life again. So to first initiate clot lysis, the bolus is given, and then the maintenance infusion is given to maintain the clot dissolution, right? So because of this fact, one resource that you must have when you're giving alteplase is an infusion pump, right? Rapid fluctuations in TPA serum concentration or serum level theoretically can cause bleeding. Now, a concept that I'm going to introduce here also is resistance to tissue plasminogen activator inhibitor 1. So that compound, that enzyme is essentially a counter-regulator found in our body, and alteplase has moderate resistance to that counter-regulator. And we're going to compare that to tenecteplase. Finally, as you see on the slide, the dose is 0.9 milligrams per kilogram to a maximum of 90 milligrams. You give 10% as the bolus and the rest over 60 minutes. Now, when to repeat imaging after thrombolysis? If the patient develops severe headache, acute hypertension, nausea, vomiting, or has a worsening neurological examination, you should discontinue the infusion and obtain an emergent non-contrast scan of the head. Now, in addition to that, 24 hours after giving the alteplase, you're to obtain an additional, to obtain a repeat CT scan, although an MRI scan is acceptable, right? Before starting anticoagulants or antiplatelet agents. Now, tenecteplase, a very interesting drug. It's efficacious and may one day be the drug of choice in thrombolizing ischemic stroke. It is recognized by both the American Stroke Association and the European Stroke Organization as an option, even right now. So it has higher fibrin specificity than alteplase, and it has a higher plasminogen activator inhibitor 1 resistance. So in those ways, it's actually superior. Now, the reason that it's not used in preference is because there's less large, high-quality trials available, right, currently, and hence it's not yet FDA approved for stroke thrombolysis. It has been around for a while as well. It's been approved for the treatment of myocardial infarction since the year 2000, but as I said, it's used off-label for stroke. Okay. Now, of note, according to the European Stroke Organization guidelines, it may actually be the drug of choice in thrombolysis when thrombectomy is expected to be done right after. And this was borne out in the Extend IA 2017 trial, which stands for Extended Time for Thrombolysis in Emergency Neurological Deficits trial. Wrapping up about tenecteplase now. It has a half-life of 20 to 25 minutes, and therefore it is given as a bolus dose. Therefore, no pump is needed, and this may be very beneficial in resource-limited settings. Now, the reason, as I said, it's given as a bolus dose is because of the longer half-life, which creates a good serum plateau concentration. Now, the accepted bolus dose is what's shown on the screen of 0.25 milligrams per kilogram to a max of 25 milligrams per kilogram. And it's given just over 5 to 10 seconds as a push. Higher doses of 0.4 milligrams per kilogram have been used, but are associated with higher rates of intracranial hemorrhage. One last thing, just for completion, reteplase in some case series has been used in stroke thrombolysis, but currently is not accepted practice as it has the highest risk of intracranial bleeds among the three. So, this chart is just to emphasize that the benefit of TPA declines with time, and therefore thrombolysis takes priority and should be done as quickly as possible. Okay, monitoring post-thrombolysis. Monitoring is best achieved according to a standardized charting tool as dictated by your institution. This is an example of the chart used at the University Hospital of the West Indies. Monitoring is best achieved in a dedicated stroke unit. However, sometimes monitoring must take place or at least be initiated in other settings as door-to needle time takes priority. Okay. All right, so now we're going to talk about mechanical thrombectomy. All right, so mechanical thrombectomy with stent retrievers is a surgical intervention of choice. And I'm going to give you another memory aid. So, to remember the indications for mechanical thrombectomy, I'm going to give you a cinematic illustration, right? Medical students on ward rounds. So, they're fit, so they don't have any gray hair or big belly yet, right? They tend to be late for the ward rounds and make the consultant angry. Their brain is young and fresh. And when you ask them a question, you realize they're not alert and they become aphasic. What does that even mean? All right, so they're fit. So they should have patients who, for thrombectomy, should have a premorbid modified Wrangling scale of 0 to 1, which means they have a good premorbid function. Late, what does that mean? So basically, studies show that thrombectomy may be beneficial in the late window, 6 to 24 hours. Their brains are fresh, so the patient should have an aspect score of greater than or equal to 6 on non-contrast imaging. And I spoke about them getting aphasic and not being alert. They should have a NIH stroke scale greater than or equal to 6. Good. So this slide says a lot of what I just said. I just wanted to highlight one thing on this slide. And this is that mechanical thrombectomy with stent retrievers is predominantly indicated in occlusion of the M1 branch of the middle cerebral artery and sometimes the M2 branch. We're going to speak about that a little now briefly. So I don't want to scare those of us who are afraid of anatomy. So this is just going to be a brief discussion about anatomy. So the take-home message, right, is that thrombectomy, mechanical thrombectomy, is indicated in occlusion of the very large vessels, such as the internal carotid artery and the M1 branch of the middle cerebral artery. And why is this? Essentially, these arteries have the largest diameter and the least risk of rupturing the vessel while trying to remove the clot. Now, there is moderate quality evidence from studies that thrombectomy has good outcomes in treating M2 occlusions also, right? M3 and M4 occlusions are typically not amenable to thrombectomy. And other large vessels on a case-by-case basis may be amenable to thrombectomy, such as the basilar artery, anterior cerebral artery, and the posterior cerebral artery. But most studies were done regarding the internal carotid and M1 branch. Okay, so this is the modified Rankin scale, right? It's a scale used to assess functional impairment, but may not adequately represent quality of life. Meaning to say that two patients with the same level of disability may have a varying quality of life. For example, according to their occupation or other requirements. Essentially, a score of 0 to 1 is an excellent outcome after stroke, and a score of 2 to 3 is good to fair. Now, this score is done at presentation based on history and at discharge and also at 90 days. And this score was a therapeutic endpoint in many landmark trials. So I'm going to give you another memory aid now. So we're going to continue with the med school predicate, right? And we're going to imagine that the modified Rankin scale represents the student's social life, the level of impairment of the student's social life before med school, during med school, and after med school during internship. I'm going from left to right. So we can imagine that at the end of sixth form, that summer, you know, they have a budding and blooming social life. By med school, there's going to be some amount of impairment, but they might be able to balance. By clinical year, third year, a Rankin score of 3, there's going to be significant, at least moderate impairment in their social life. Not to mention by final year, meaning 5th year, right? There's going to be severe impairment. And then internship now, 6, that speaks for itself. All right, moving on. So mechanical thrombectomy. How do we know which vessel? How do we know that they're salvageable tissue? So we know which vessel based on angiography. How do we know if they're salvageable tissue? Well, different studies use the different parameters, and we can combine all of them in our clinical practice. So we're going to speak about some of the landmark trials now. The Mr. Clean 2015 trial, a big one. So Mr. Clean stands for Multi-Center Randomized Clinical Trial of Endovascular Treatment of Acute Ischemic Stroke. Now, it was the first successful large thrombectomy trial, and it proved that thrombectomy works for persons who are carefully selected less than 6 hours after stroke onset. No penumbral imaging is required or was required. Now, more recently, the diffuse trial, well, specifically diffuse 3 trial of 2018. So we're going to compare the diffuse trial and the next trial, which is the Dawn trial, right? So the diffuse 3 trial used image-acquired perfusion mismatch parameters, right, with CT perfusion or MRI to determine who had good penumbra left, right? So diffuse stands for, right. So the endovascular therapy following imaging evaluation for ischemic stroke 3 trial. So I have another memory aid for you for diffuse 3. So the diffuse 3, right? We can remember information about diffuse 3 with the rule of 6 and 3. So I'm going to give you 6 parameters. So 1, diffuse is 6 letters. 2, disabling stroke, an NIH stroke scale of greater than or equal to 6. 3, they tested a window of 6 to 16 hours. 4, this is where the 3s come in now. They used a penumbra to core ratio of 1.8, which is 3 by 0.6, all right? They had 180 patients, which is 3 by 60. And finally, 36%, so this is number 6, 36, again, 36% of the patients had excellent outcomes. So that's the diffuse trial. Diffuse 3, all right. So now we're going to talk about the Dawn trial of 2018. Now this used clinical core mismatch parameters. So diffuse used imaging to determine who had penumbra. Dawn essentially said, okay, who looks like they have a bad stroke based on NIH stroke scale, and they used a value of 10, and then they looked at their CT perfusion or MRI scans, and if the core was small, they said, okay, the fact that they have such severe clinical symptoms, but the core is small, means that they have a large penumbra, a large area of functional impairment that's amenable to therapy, right? Now, for the persons who are familiar with these trials, there were a lot more inclusion and exclusion criteria and other details, which I really don't want to overwhelm the audience with, but I'll at least make mention of it, that I'm simplifying the information. Now, how you can remember the window for the Dawn trial is from dawn to daylight, which is 24 hours. So what am I talking about? People usually say dusk till dawn. That's only 12 hours. So this is from one dawn, one morning to the other. And so they tested the benefit of thrombectomy over a 24-hour window, right? Moving on. All right, so supportive care in patients with stroke. Supportive care during the acute phase can be medical or surgical, and patients should be admitted to a stroke unit where available, right? Now, to condense the information, I'll highlight that there is some overlap in the care of ischemic and hemorrhagic stroke, and I will also highlight the differences. So supportive care, the key aspects are airway and oxygenation and ventilation support, blood pressure control, hydration, evaluation and treatment, glycemic control, temperature control, management of complications such as raised intracranial pressure, and management of, again, complications such as seizures. So just take home messages about these points, right? So for airway support and ventilator assistance, patients with decreased consciousness or who have bulbar dysfunction that causes compromise of the airway should get airway support and ventilation assistance. We should aim to maintain an oxygen saturation of greater than 94%, and supplemental oxygen is not required if the patient is not hypoxic, right? And this is according to both the American Heart Association 2019 guidelines and European Stroke Organization 2021 guidelines. In terms of blood pressure control, right? This is, I don't want to say it's a controversial area because the guidelines are clear, but one, ideal blood pressure targets in acute ischemic stroke remains unknown, and there are only 3 indications for antihypertensive therapy in ischemic stroke. So the first one we all know, if you want to thrombolize the patient and the blood pressure is high, meaning greater than 185/110, then yeah, we need to do something about that. We need to rapidly reduce the blood pressure, right? It's a hypertensive emergency, and we want a blood pressure of less than 180/105 before we can, institute thrombolysis. Now, what if the patient is not amenable to reperfusion? Maybe they came really late and they still have a really high blood pressure. So if the blood pressure is greater than 220/120, you can consider gradual blood pressure reduction over 24 hours by 15%, all right? So it should not be rapid, it should be very gradual. And the reason is this hypertension is compensatory, right? And it is maintaining some perfusion to the ischemic penumbra. So rapidly dropping the blood pressure tends to actually worsen the stroke. And the final indication is if comorbid life-threatening conditions require rapid treatment of hypertension, such as aortic dissection or left ventricular failure, then that may take precedence. Going through the rest now, so hydration status and fluid management, this should be individualized. We should aim for euvolemia and avoid hypotonic solutions. In terms of glycemic control, both hypo and hyperglycemia are associated with poor outcomes. We should aim for normal glycemia, and we should treat any hypoglycemia. In terms of temperature control, fever is also associated with poor outcomes. So pharmacological treatment is fever is recommended. We should identify and treat sources, and the benefit of treatment with induced hypothermia is uncertain and not supported by the evidence. The complications now. So management of raised intracranial pressure at the bedside includes elevation of the head of the bed between 30 to 45 degrees and keeping the head midline, appropriate analgesia and sedation as required, and osmotic therapy or brief hyperventilation may be used to tide the patient to definitive neurosurgery as is indicated, right? But these, I would like to emphasize that these are temporizing measures. And seizures. So the guidelines say prophylactic use of antiepileptics is not supported by the evidence. And also the treatment of seizures, if they occur, are treated as others. So there's no specific management of seizures directed for stroke patients, right? Just manage them as you would normally manage seizures. Okay, supportive surgical care. This may be indicated for raised intracranial pressure, and it may include, as directed by the neurosurgeon, interventions such as intraventricular drain placement, invasive monitoring of the intracranial pressure, decompressive operations. A bit about hemorrhagic stroke now, the most important points and the differences in management from ischemic stroke. So, as I said, much of the management is the same, but reperfusion strategies are not indicated as the management is predominantly supportive. Aspects unique to hemorrhagic stroke. Well, one, blood pressure control. So the blood pressure is reduced to a target, so reduced rapidly to a target of 140 systolic over an hour, and then maintained between 130 to 150 systolic. Initial injury in the first 6 hours is due to hematoma extension, and thereafter is secondary injury is due to raised intracranial pressure. So blood pressure management is aimed at reducing hematoma extension. And there's a lot of evidence for this in the literature, and it is recommended by the 2022 European Hemorrhagic Stroke Guidelines. Okay, good. So in terms of hemostatic therapy, it's given to reduce the progression of the hematoma if these patients are on anticoagulants or if they have evidence of coagulopathy. And the agent that you use will be dictated by what type of coagulopathy the patient has. So we're not going to go into great detail about that now, but you need to be aware. In terms of surgical management of hemorrhagic stroke, you know, this is really the purview of the neurosurgeons again, and it could include craniotomy, decompressive craniectomy, stereotactic aspiration, catheter aspiration, and other approaches. Okay, so we have gone through the bulk of the information for current stroke management, right? And now this is just going to serve as a primer to let you know some of the things that are going on for the future of stroke care. Okay, so improvement in acute stroke diagnosis. Well, two big topics are mobile stroke units for pre-hospital diagnosis and biomarker-based rapid blood tests for stroke detection. I'm going to just speak about them briefly. So what's a mobile stroke unit? It's a specialized ambulance equipped with advanced medical technology, including a portable CT scanner, right, allowing healthcare professionals to diagnose stroke on site. The idea was proposed in 2003, and the first trial was in 2009 in Germany. Now, there's a worldwide initiative for mobile stroke units. It's most useful in rural settings in resource-rich countries, because as you can imagine, you need a lot of resources for this. And it's also used in densely populated areas. Now, most of these mobile stroke units have on it EMS personnel, a radiology technician, a nurse or nurse practitioner, and a neurologist may be on board. Although it allows access to telemedicine, where the other members, the other personnel on the unit can institute management as directed by an off-site neurologist. So some randomized trials demonstrated that these mobile stroke units increase thrombolysis rates and decrease the time taken to thrombolysis. Okay, just briefly about biomarkers. Okay, so trials are ongoing, right, for point of care stroke identification tests. And basically they use antibodies to detect serum biomarkers released by infarcted brain tissue. And basically some of the ones being tested right now are being used to try to identify efficiently patients with large vessel occlusion. As again, I said, because as I said earlier, these patients would benefit most from therapy at a thrombectomy capable facility. There are also serum biomarker tests. This is just a few of them. There were a whole lot. And they're not, most of them are being tested still, right? So there are no guidelines really on their use. But things that researchers are looking at are differentiating ischemic versus hemorrhagic stroke with these biomarkers, estimating the amount of penumbra that can be salvaged, predicting hemorrhagic transformation after thrombolysis, and predicting stroke recurrence. Okay, in terms of emergent treatment strategies, one of the main things that persons are looking at now, researchers are looking at now, are new generation thrombolytics. In addition to that, there is research into extending the thrombolytic window and advances in mechanical thrombectomy. So just going to touch on those briefly. So this company is Thrombolytic Science LLC. It was founded in 2006 by a Harvard graduate, Victor Gurewitch, and they are currently conducting tests on dual thrombolytic therapy with mutant prourokinase with alteplase. So a 2023 study was already published that showed no added benefit, but also no increased bleeding risk. And so further studies are ongoing. Briefly, in terms of extension of the thrombolytic window, there's the TRACE-3 trial, which was done in 2024, which is tenecteplase reperfusion therapy in acute ischemic cerebrovascular events. The short version of this story is that they used imaging characteristics to see who had salvageable penumbra within the 24-hour window, right? And they found that a lot of persons who got tenecteplase, they benefited, and the improvement to complication rates were acceptable, right? In terms of the HOPE trial, which is hyperacute or periacute stroke evaluation trial, it started in 2024 and it's ongoing, and it's also testing that late window of 4.5 to 24 hours. Finally, I'm mainly going to focus on this slide about robotic assisted thrombectomy. So the take-home message about this is that this can allow surgeons to perform thrombectomy remotely. So if you have a major facility where neurosurgeons are present, and at a rural facility, you have the device that is robotically controlled and can be controlled remotely, surgeons now can have access to patients who are amenable to thrombectomy and improve their outcomes. So, take-home points from this presentation. 1, 31 years ago, stroke care was only supportive, right? So we have come a far way. Therapeutic stroke care requires a lot of resources. Despite this, we are privileged to practice medicine in a period where we can offer patients therapeutic options. And finally, we must continue to advocate for the resources so we can intervene quickly and improve our patients' outcomes. Thank you for your attention, and I hope this was beneficial to you. These are my references rather.
Thank you, Dr. Carlton Miller. I must say that was a very informative presentation. We'll now have a brief question and answer session, but before we get into the questions in the chat, we want to formally introduce our panelists and ask them 2 questions of our own. So our first panelist is Dr. Tamika Marchdona. Now, she's a consultant neurologist at University Hospital of the West Indies here in Jamaica, and she's known for her work in stroke care and her role in the rollout of the Mission Thrombectomy 2020, which is a global initiative aimed at improving stroke care. She's an advocate of the importance in increasing the risk factors for stroke, and she often emphasizes the importance of recognizing early stroke signs. And she highlights often that the time is critical in stroke treatment. So, Dr. Marchdona, can you hear me? You can unmute your mic. What are
Hello, good evening. Yes, I
Greetings.
can.
Yes. What are the key challenges you foresee in establishing a dedicated stroke unit in a resource-limited setting?
And thank you so much for inviting me this evening. So a stroke unit is not a location alone. It is a specialized, dedicated area with a team that is trained to treat all types of stroke. So as you can see, we already have a limitation because we don't have a team as yet. We are building out a team, but we don't have the full complement. The full complement include all physicians who are stroke trained nurses, a stroke nurse coordinator, a stroke research nurse, and the actual physical location, there is no bed limit. It can be a 4-bed space, a 2-bed space, a 3-bed space. So the actual location is not a problem. We are faced because we don't have an actual location, and our patients, they are placed where a bed is available. So for example, the patient is placed in the emergency room, then it is the emergency room nurses who would have to now take up the responsibility of doing the monitoring, which means all the nurses have to be trained because you never know which shift the patient is going to be on. If the patient is on ward 4, all the nurses on ward 4 has to be trained because you never know which shift a stroke patient. That being said, we have quite a lot of shortages of nurses, and the training is really a specialized training. It's not something that you just decide that, yes, you want to do, and that is it. you have to be trained. Now, angels have made it easier for us because most of the training can be done remotely. It is extensive. The nurses training component requires 21 modules to be done. And so far, we have not had not even one of our nursing staff who has completed 5 of those modules. So that is a big challenge for us. And therefore, having a set of persons rather than trying to get everybody involved, which is going to be difficult, is to go back to the original model of having a dedicated set. The patient will move from point A to point B to a well-oiled, engineered set of team that is capable of managing all the complications and all the nuances of stroke. Why this is important is because in the identification of stroke, you also have to identify the mimickers. It's not just about the imaging, not just about the TPAs, but what do you do to mitigate reducing your risk of TPA in a patient that is a mimic, that is a stroke mimic, that comes in with a hemiparesis and a facial droop. That requires a team that is trained to be able to pick that up. All the studies have shown that stroke patients will do better with a stroke-centered care. All the studies are clear on that. And therefore, we are moving forward. We have made significant improvements. So I'm happy for that. We should have an additional person joining us soon on the stroke train. So that will definitely help us to chart out a path that is more streamlined for the patients, thereby reducing their morbidity and therefore improving their level of care.
Thank you, Dr. Dono. So a lot of challenges in the near future, well, to be tackled in the near future. Second question, what protocols, if any, would you recommend for the rapid assessment and triage of stroke patients in a tertiary institution? So to ensure timely administration of a thrombolytic or any other acute intervention.
Okay, lovely. I was most happy to see our second speaker mention the VAN, V-A-N. I was most happy to see that our current protocol combine the National Institute of Health Stroke Scale Score and the VAN. Reason being, the NIHSS score, though it is a validated score, and it gives us an idea of your 90-day mortality, it gives us an idea of your severity, and it can predict to a good specificity your large vessel occlusion. It doesn't do very well for posterior circulation, and that's why we added the VAN. So we added the VAN for the posterior circulation, and we added the VAN also because the VAN has a very high, almost 100% specificity as it regards cortical involvement, which is important in the large vessel occlusion patients. So when we combine a stroke scale score of greater than 6 and one positive feature from the VAN, which is what our protocol now dictates, that will give us a 100% sensitivity of identifying a large vessel occlusion and a 90% specificity of identifying a large vessel occlusion, which is wonderful. Of course, we are going to miss 10% of the patients because all scores are going to have some limitation. But combining those two scores gives us a better outcome than using either or. Why we implement this is because the gold standard is that all patients should have a non-contrast CT and a CTA. Unfortunately, we have our challenges and all patients cannot at this point in time have both. So rather than having 100% sensitivity, 100% specificity, because we have a CTA, we're getting 190, which is a slight trade-off. So I was very happy to hear that being mentioned by the second speaker. For the triaging aspect of rapid identification of stroke, because it has to start there, the BFAST is what we will use from the triage aspect. Most persons will know the Rosier score and the FAST ED. Those scores are good. The problem with them is that their false positive rate is very high. And therefore, you want a score that is sensitive, that is specific, and their false positive and negative rate are low. Then you know you have a good score. So the BFAST, B is for balance, bringing in our posterior circulation, E is for eyes, looking on that double vision or that loss of vision in one hemisphere. F is for face, A is for arm, S is for speech, T is for time. That gives us a sensitivity of 68%. Again, a little bit on the low side compared to the Rosier that have a 50% is a little better, but it is specific 85% of the time. So again, we're getting a little bit of a better end on it being very specific. So BFAST for triage, NISH stroke scale score, and the VAN for those who we want to look if they have a large vessel occlusion are the two scores that have great values for those who are in our region who cannot do what the gold standard is, which is a CT and a CTA.
All right, thank you very much, Dr. March Dono. I'd like to introduce our second panelist, Dr. Kevin Wade. Now, he's a distinguished consultant neurosurgeon and primary neurovascular specialist here at the University Hospital of the West Indies, Mona, and he has been at the forefront of advancing surgical techniques and patient care in neurosurgery locally. And Dr. Wade, is the University Hospital of the West Indies a thrombectomy capable unit? If Dr. Wade can hear.
Hi, good afternoon or good evening, everyone.
Yes,
I'd
Dr.
like to thank the emergency department for inviting us to this forum, which I think is a extremely important type of session, both for education, management, and for advancing our goals of improving patient care. I think I'd like to just take the opportunity to congratulate the emergency department residents for an excellent presentation and update on the management and where we're coming from, where we are and where we'd like to be as far as stroke therapeutic intervention is concerned. So the short answer to your question is yes, the university hospital is capable of doing thrombectomies.
All right, thank you. And what are the key challenges you foresee in establishing a dedicated thrombectomy unit in a resource-limited setting?
Yes, so a thrombectomy or hyperacute stroke care in general is perhaps the top agenda of any modern hospital worldwide. And in saying that, it is also one of the most difficult to implement because it has so many moving parts. From the pre-hospital triage and bringing the patient to the hospital, to the initial triage and getting the scans done, to decision-making about thrombolysis, and then the consultative process about thrombectomy, then getting your thrombectomy procedure done, then your post-operative care, and usually in a stroke unit, and then from thence to rehabilitation, stroke rehabilitation, which are all part of the care pathway.
Sorry, Dr. Wade, you can go ahead.
Yes, it is the single most difficult therapeutic strategy to implement. So that being said, if we had to take the major challenges to stroke thrombectomy at the University Hospital, you would have to probably say the number one would be resources. Simply put, the devices, the catheters, the stents that you use for the procedure itself are exceedingly expensive. And this is on a per case basis, and it's several magnitudes more expensive than TPA. And it's more expensive than even doing a PCI, a percutaneous coronary intervention, just the implants alone. So that creates a significant barrier to the majority of our patients who are uninsured and come from a low economic background to be able to access that level of care. The second most important aspect of it is how do you manage a patient following a thrombectomy? And this is reflected in some of what Dr. March had said in terms of, what constitutes a stroke unit, because after a thrombectomy, typically the patients would go to a stroke unit. And then the challenges we have are common in terms of whether the patient is getting thrombolized or getting a thrombectomy, in not having a formal stroke unit at our disposal. And a stroke unit, as Dr. Marsh said, implies that you have not just equipment and monitors and infusion pumps and, the array of things that you might need for neurocritical care, which is what it is. You also need trained staff and, nurses to staff, trained stroke care nurses to staff that unit. That is a major challenge. As a proxy, things like having a intensive care unit or a high dependency unit is one way to solve that problem. But as it stands, as we know, the ICU is largely oversubscribed and also short on nurses. So effectively, and we don't have a HDU, as far as I'm aware, that is outside of the ICU. I don't know if there's a NICU. I don't know if there's a functioning HDU anywhere else or properly functioning HDU anywhere else in the hospital. So effectively, that creates a significant limitation in the same way that many complex and advanced neurosurgical procedures end up in that situation. Same way that your ketoacidosis patients or your asthma patients with respiratory issues or your septic patients, in the same way that there are challenges gaining access to neurocritical care in a timely fashion, it invariably is going to affect any patient with a stroke who needs access to this service. And stroke means now. So, it's not a situation where you can try and stabilize and then hopefully something works out in the next little while. It's really, you really lose that window, as you showed us, as your speakers showed us. Once you start getting further down in that window, the odds of success go down, and the risks increase from doing the procedure. So the risk-benefit trade-off, especially in a low socioeconomic setting, make it very challenging to try to do a thrombectomy later down in the window when you likely have large core volume infarcts. The other challenge, I think, perhaps is something that I think we have been working at it as a hospital through training, through doing various meetings with the Mission Thrombectomy Group and the World Stroke Organization, the ANGELS Initiative, and with Dr. Marsh Downer as our head of the stroke task force, is how do you streamline patients through the hospital system? So we don't have much control over the pre-hospital part of management of the patient. But once they hit our doors, how do we improve the efficiency and efficacy of moving the patient through the system so that they will arrive at a decision point in a reasonable time for a discussion about thrombectomy to make sense? And I think while we have made some, progress on it, I think there's still some work to be done in that respect. So I would say that though we are certainly stroke capable, there are significant challenges that we still face.
Thank you very much, Dr. Wade, for the insight on the challenges faced. All right, so now we're gonna take a few minutes just to answer some of the questions in the chat. We're gonna answer 2 questions because of time constraints, but we believe Dr. Marchdown and Dr. Wade, you may be more equipped to answer 2 of these questions. So, Dr. Marchdown, are there any studies that show the difference between the complications or outcomes using estimated or actual weights for thrombolysis? We know that if you overestimate the weight, then the risk of hemorrhagic transformation may increase. But do you know of any study that demonstrates same?
No one actually, you're not going to find any because we really should be doing weights. We really should be doing weights. All of our treatments are weight-based. So although we don't have yet weighted beds, we are guesstimating, estimating, and whatever else we do to try to figure out the patient's weight. We have not suffered, knock on wood, complications, but you can foresee the troubles if you overestimate or you underestimate. You underestimate, you don't get the results that you should have received because the patient received a lower dose than is recommended, and you overestimate, you expose that patient to undesirable effects that could have been averted if the actual weight was used. So we are in the red arrow plus for that one.
Thank you very much. And Dr. Wade, well, the question states, what was the rationale for neurosurgery, if available, in the second case for no surgical intervention despite the patient having an infratentorial bleed and an acute hydrocephalus?
We would have to go back to the exact clinical parameters of the case and the exact findings on imaging. All decisions in medicine are based on a risk-benefit analysis, and it is related to where you meet the patient at the particular time in their course and the likely benefit that they will have to whatever treatment you're going to implement. So in the case where you have a patient who is in extremis, okay, a very sick patient, especially if it is that you would have to put up back some of the exact case so I can remember some of the specific clinical parameters. But the idea is that if the patient is already at extremis and has a very poor neurological grade, and especially if they have been that way for some time, the chances of recovery with the best of surgeries in the best of centers with the highest volumes, it's still quite poor. And in our setting, one of the issues that we tend to have is that we don't have any critical care support. And in fact, perhaps even more important than surgery sometimes is having neurocritical care support. So we run our own numbers because we've been very proactive with being data-driven. And we have found that in patients who are at extremis who need neurocritical care, as in ICU, and ICU is not available, the odds are survival are slim to none. So if you're in a patient who is severely ill, who is unlikely to benefit from treatment and will only benefit in the setting where you have an ICU space available post-surgery, if there's no ICU space, the odds are simply stacked against the patient. And in that setting, it might not be worthwhile to proceed. Okay. In general, some posterior stroke, fossa strokes do respond well to surgery. But in cases where the patient is at extremis, it is unlikely of benefit. The one type of stroke that in the posterior fossa that certainly is non-operable would be a brainstem hemorrhage type of stroke, or ischemia as well. Ischemia, or in fact, in the brainstem itself, is not something that is usually treatable. And in fact, we have had some recent cases with that very issue, where they have had a severe brainstem hemorrhage. And unfortunately, there's really not much, that can be done in that case.
All right, thank you very much, Dr. Wade. Dr. Bruce, Dr. Carl Bruce, I see has joined. We'll open the floor to you, Dr. Bruce.
Yes. Are you hearing me now? Hello?
Yes, hearing you, Dr. Bruce.
All right. Thank you very much. And I'm definitely going to ask for some latitude as the chief of staff of the hospital on this one. So I do have a few comments. But let me just ask a quick question of the panelists. If I could just ask Dr. March Downer, that's a simple question. Of all the things that you're putting in to get stroke accreditation, let's say you have 100 things, personnel, etc., that you need. Where would you say you are now? What percentage you would say you are in terms of where the hospital is with the different things that we need? Just a percentage. Dr. March Downer?
Well, good afternoon. Hi, Dr. Bruce.
Hi, Dr. March Downer.
Yeah, so in terms of the things that we need, we are, I would
No,
say,
not what we need, or just what percentage we're at.
yeah, no, I'm going through. In terms of the things that we need on a recommendation basis, we have actually reached almost 80% of those recommended things on that list that we need for
80%.
accreditation, about 80%.
All right, thank you very much for that.
Mandatory list, we are a little bit short. We're just at 43%. So we're not awfully bad. As I said, we're coming from near zero. So we're moving forward.
80%. Thanks.
Yeah.
And Dr. Wade, can we do a thrombectomy at the University Hospital?
I believe I answered earlier that we are capable of a thrombectomy, yes.
Okay, and about when you would say we got the capability to do a thrombectomy?
This would have been maybe 4 or 5 years ago.
Okay, all right, thanks. Chair, just allow me a few comments. Let's first of all congratulate the residents. I did join from case one, chairman, and I want to congratulate the staff. I thought it was an absolutely brilliant presentation, and I think Dr. Miller, I believe his presentation is that's definitely world class, complete with, I think, lots of visual and learning aids. And I hope it's recorded and that we can share it. It would have been good to see some more of the A&E consultants on. I see Dr. Hudson as the only consultant. Perhaps there are others, but that's a bit disappointing. But I really want to congratulate you guys. This is outstanding work.
Thank you, Dr. Bruce.
You're welcome.
Consultants are all on YouTube watching.
Okay, thanks. The second thing I would say is, we started this institution out in the colonies in 1948, and believe it or not, the very man that Dr. Miller showed, Winston Churchill, used the Colonial Development Fund. Maybe ample name for the criticism I have this evening, the Colonial Development Fund. And he himself came to the University Hospital in 1953 and opened the University Hospital. And, it's remarkable that he was mentioned by the accident and emergency team this evening as, dying from a stroke. But it's the Colonial Development Fund that started us. And I believe that's where my criticism begins, because I feel that as an institution, that 80% is a lot of progress. I feel as an institution that there are a lot of things that I see that we are underutilizing. I think we have the most advanced in terms of diagnostic equipment. I think we're very advanced in terms of thrombectomy equipment. I know we have challenges in terms of the cost of disposables and pharmaceuticals. But the last time I ran a stroke code, I believe Dr. Thorburn was able to provide the medication that we needed. But I think all of us should be aware that there's nothing called free healthcare. It comes at a cost. And therefore, we're going to have to find ways of covering the different thrombolytics that the patient may need and the different disposables that the patient may need, and not fool ourselves to believe somebody's going to come out of the woodwork and provide these funds or resources. But what I would want to say is that there seemed to me to be a lot of growth, and there seems to be a significant, we're down a pathway which is very significant in terms of stroke capability from the emergency room, from radiology, from neurology, neurosurgery. We just had Dr. Marie Williams complete a stroke fellowship. Dr. March Downer herself. We still have 2 other stroke fellows who are away. I've seen a lot of progress in, as I said, radiology and in intervention. We see a lot of progress in rehabilitation. We now have a rehab specialist. We finally have a speech and language pathologist, physiotherapist, occupational therapist. So I definitely see a lot of progress that you guys should congratulate yourself about. But then it becomes whether the glass is half full or half empty. And I'm supposed to bring the vision and the strategy. And I want to suggest this evening that we move out of the colonial era and move out of that era where we were slaves and start thinking about how we can do it ourselves. Nobody's going to hand it out to us. If we have all of these advanced knowledge that was presented this evening by the A&E staff, and we have all of this advanced equipment, then we can't sit around and wait for somebody to buy us alteplase or tenecteplase. We're going to have to make it happen. And this hospital has a long history of people talking a lot and sitting around waiting on things to happen. You make it happen. And if you don't make it happen, new units are never created. New professions are never created. New specialists never come on board. And so I think we need to start thinking that the glass is half full or 80% full so that we can take the next step towards stroke accreditation rather than spend a lot of days belly aching, as the great Archibald MacDonald OJ would say, on what we don't have. Let's kind of focus on what we have and where we need to go as a developing country and where we need to go as a people who are now leading ourselves and not dependent anymore on the Colonial Development Fund. So I think we need to look at our own strategy, look at our own vision, be positive and congratulate our colleagues about what we've done, form teams that can get things done, and move the ball forward. If the ball gets forward, we will score. But if we're constantly on defense and making excuses, then all that's going to happen, a nil-all game you're going to lose. So I think there has been a lot said. And again, I want to congratulate what has been said here this evening. But I think that we have come a far way and we need to push ourselves to get over the limit. Thank you very much, Chair.
All right, thank you very much for that insight, Dr. Bruce. All right, so we're gonna end today's grand rounds as we're over time. But on behalf of the University Hospital of the West Indies Emergency Medicine Division, I'd like to thank you all for participating and tuning in. You all contributed to tonight's success. I am sure the presentation stimulated your imagination regarding the past, present, and future of stroke management. I want to thank Dr. Wade and Dr. March Downer for your knowledge that you imparted to us this evening. A heartfelt thank you to our presenters, Dr. Zachary Gordon and Dr. Carlton Miller, for sharing invaluable insights into stroke management. And I cannot leave out Dr. Rhonda Hudson, or accident and emergency consultant that has been providing technical support to us right here in this room. Special thank you to Dr. Errol Williamson, our team leader, for organizing this evening's grand rounds, and I would like to also thank Dr. Monique Pusey, Dr. Kendrina Lewis, and Dr. Tony and Duncan and Stacy and Tennyson as they assisted us this evening, providing our background support. And we need to also extend our deepest appreciation to Dr. Romaine Edwards, or coordinator, Dr. Simone French, or course director, and of course our head of department, Dr. Eric Williams, and all other consultants for their continuous stewardship. Thank you all, participants, for your engagement, your questions, and your commitment to improving patient care. Let's continue on our mission to save lives through knowledge, collaboration, and excellence in emergency medicine. We look forward to seeing you at our future events. Thank you and have a good evening.